Hi there. Welcome to the California Initiative for Health Equity and Action's evidence briefing on expanding California's behavioral health workforce in response to COVID-19. California's longstanding challenges of addressing behavioral health have been heightened because of the COVID-19 pandemic, and Californians are increasingly worried, anxious, depressed, and many are turning to binge drinking and substance use to cope with economic and social uncertainties. And what we need is a robust interdisciplinary workforce to meet the needs of Californians that are struggling with behavioral health challenges. Today, CalIE has assembled an expert panel of UC faculty and the Office of Senator Bell, in addition to Stephanie Welch of the California Department of Health Services, to highlight some promising opportunities in expanding the behavioral health workforce in the time of COVID. So we are very pleased to have you all join. And I wanted to remind the audience here that you can use the Q&A functions to submit any questions that you have to the panelists. And the questions may be answered during the Q&A as the panelists are going, but the webinar panelists will be able to engage in answering these questions during the Q&A as well, which is towards the end. And use the chat function for any general questions or comments that come up during the briefing. So we look forward to your engagement and participation. Now, we're very fortunate to have a pioneer in behavioral health with us today, Senator Jim Bell, California State Senator of the 15th Senate District. Senator Bell has spent over 4 decades in public service, first as a San Jose City Councilman, then as a Santa Clara County Supervisor, legislator in the Assembly and Senate, and he has created landmark legislation, including policies to ensure that victims of sexual abuse have the appropriate criminal justice reforms, the creation of mental health services funds, which channeled funds to local mental health programs, mental health de-escalation training for peace officers in order to reduce violent confrontations with people suffering from mental health conditions, and the establishment of youth drop-in centers to treat mental health needs of California youth. And most recently, a statewide peer training and certification standards for peer support services, which allows counties to draw down millions in federal funding. We're so pleased to have him give us our opening comments for this briefing on behavioral health workforce. Thank you, Dr. Bell, or Senator Bell.
Hi, everybody, and thank you for inviting me to speak to you today and about health equity and action and behavioral health. It's really a timely subject given the situation we're all in right now. And I hope we can recognize any legislators that are attending, if possible. Please let us know that you're out there. Over my term through the legislation, I have focused on mental health and issues like mental health parity, getting more funds in the department to coverage for mental health, addiction treatment, peer certification, and access have been very important goals that I've established over my career. And I was checking the other day, I have about 12 bills that were signed into law over my term of office. And hopefully they're going to have a great impact on the mental health system in California. But I think there's a lot of work to do. And there's a lot of work to do because of the situation we're in, where a majority of the people in California do not feel they have adequate mental health services. And for those that are politically minded, I've done political polls, and I've seen political polls that show that voters really pay attention to politicians that want to improve the mental health and substance abuse treatment system. And when you put that survey question to the voters, they're more likely to vote for a candidate that supports stronger mental health and substance abuse treatment, and less likely to support a candidate that is silent on the issue or ambivalent or even opposed to the issue. We're a situation we're in now with the coronavirus. Yes, we're having a lot of impacts that we're starting to see. we're starting to see impacts because of our inadequate, to begin with, mental health and substance abuse treatment system that we have in California. I'll just mention a few outcomes that we're starting to see. I'm concerned about being a grandparent of a student outcomes and the anxiety and mental health situation that we have in the schools is an issue. We have higher domestic violence in our communities. I can tell you, my office gets calls, and we're hearing higher domestic violence, families that have suicides, families that have had fentanyl overdoses have all called into my office, higher mental health problems, family problems, just having violence in domestic situations. The stress is real, and people have a lot of anxiety, and so do every member of the family. This is why I think this year was important that we passed two important mental health bills that I'll mention. SB 855, which I co-authored with Senator Weiner, and this is the mental health parity, and it affects the medically assisted treatment and getting mental health parity, medically necessary defined so that you have the doctor's version of what's medically necessary prevail. The other one was SB 803, which is my peer support bill, which established a statewide certification so we can get billing Medi-Cal for certification. The governor signed the bill. The bill will classify peers as a specific provider type, which allows billing to occur, allows counties to have access to federal funds, and creates a statewide training standards for peer support programs. Instead of the counties are allowed to opt in to this program. That was a concession that we had to reach. We've had a hard time, getting our bills through on mental health. I look back over my career, and I'm about a 50-50 average on the subject. But I think, for example, we tried the parity bill. I think it's 4 times, some version of parity or parity enforcement. But I think that we have to recognize that we're fighting against disparities for people of color in terms of mental health services. We're fighting against just sort of the biases and discrimination, I call it. I don't like to use the word stigma. It's really too nice of a word. It's really bias and discrimination in actual fact towards the whole subject of mental health by some people as not a qualifiable medical condition that needs preventive and a whole range of services. And I think that an example of that is when we lost SB 854 this year, which was a bill that required substance abuse treatment to be provided for medically necessary substance abuse treatment to be provided at the call of the doctor, which of course would reduce drug overdoses. I felt bad when I got a call from a parent this week about a fentanyl death in their family. And they wanted my help on that. And I also got a call on suicides. In fact, we might even have a suicide that we're trying to investigate in my own family that occurred recently. So I feel that we have a long ways to go. We have to overcome prejudice. We have to have elected officials that set the tone and the standard for what the policies of California should be, and to remove the disparities. Disparities in persons of color is a major problem in the mental health. It's been made worse by the COVID situation, in my opinion, especially children that have various kinds of learning and developmental disabilities. And I know that what's that like because I happen to be a parent of somebody that has both a mental health condition and developmental disability. So I feel that these are issues that we ought to focus on and work on throughout the COVID crisis. And it's been my goal to ensure that that be done. I look forward to being an advocate next year as opposed to a senator. And I thank you all for your attention to this issue. It's so important. And thank you for your efforts, all of you, to make our state have better mental health and substance abuse services in our state. Thank you.
Excellent. Thanks so much, Dr. Bell, for those words. We're so pleased to have your pioneering efforts in the state. Next, we have Professor Janet Kaufman, Professor of Medicine at UC San Francisco. For nearly 2 decades, Professor Kaufman has served as a bridge between academia and California policymakers. She's widely known for her important contributions to health workforce in California and the United States. She has authored numerous articles and reports on supply and demand of healthcare workers, geographic maldistribution of the workforce, and strategies for improving racial and ethnic diversity among healthcare professionals. Dr. Kaufman received her PhD in Health Services and Policy Analysis, as well as her master's degree in Public Policy from UC Berkeley. Thank you, Janet, for joining us today.
So a few points as we move along. As Senator Beal has noted, the pandemic has increased need for behavioral health services. What I think the role of my presentation is to provide some information about the behavioral health workforce and estimates of future supply and demand. I think this is important for developing and advocating for policies to address needs. And these are pre-COVID data. So think of the data as sort of where we were, say January-ish of 2020 prior to the pandemic. I also want to talk a little bit about gaps in data about the behavioral health workforce. So just briefly here are some national data from the National Center for Health Statistics Household Pulse Survey on the prevalence of depression and anxiety symptoms among Americans nationally. And you can see big jump ups between January, June of 2019 to April, July of 2020. And so I think this just is some quantitative data that underscores the point Senator Beal just made about the prevalence of depression and anxiety. There's certainly increases in substance use, and Dr. Martine, our next panelist, will discuss that. This slide is intended to give you a sort of big picture overview of the behavioral health workforce in California. I should say the licensed behavioral health workforce. And there are about 98,000 of these folks in 2020. And these are folks who have an active license. So you can think of this as sort of the maximum supply of licensed professionals. Now, some of these folks may not be working at all, or they may not be working in behavioral health. But to give you sort of a lay of the land, the largest chunk of the licensed workforce is LMFTs, which stands for Licensed Marriage and Family Therapist. And the next largest chunk is licensed clinical social workers. Now, it's really important to know who's not on this graph. And that is those folks who work in behavioral health who do not have a license. They work in professions where a license is not required. So these may be some substance use counselors, folks doing case management, and especially peer providers. And it's really as only with the legislation that Senator Beal succeeded in getting signed into law this year on peer certification that will really have some sort of way to track statewide. One could, to some extent track these folks through records of county behavioral health agencies, but even that doesn't give you the full picture because a number of peers are volunteers. And I believe Dr. Science will touch on this. Some of these folks, because they have disability, there are real limits to how much they can work and still keep their disability benefits and the health insurance that goes along with it. Now I want to talk about geographic distribution. Senator Beal is absolutely right that we struggle with access to behavioral health across the state, but certain areas of the state, folks struggle more. And I've highlighted here in yellow and red the Inland Empire and the San Joaquin Valley. These are the areas in which most of the professions, they have the lowest numbers of behavioral health professionals per capita. The exception would be over in the right for psychiatric technicians, where their supplies are relatively robust. Psychiatric technicians are a niche occupation. You primarily find them in state hospitals, correctional facilities, other residential facilities, and these facilities happen to be concentrated in the Central Coast, Inland Empire, and San Joaquin Valley. So that's a little different. But when we look at who's out there really serving the general public with mental health needs, those two areas have some of the lowest supplies. Senator Beal touched on the importance of racial ethnic diversity. We certainly have seen disparate impacts of the COVID-19 pandemic on Black and Latinx Californians, and also disparities pre-COVID. And one of our challenges, I think, here is the lack of diversity, particularly among psychiatrists and psychologists. Blacks and Latinos far less represented among them than they are in the population. Better representation among folks with master's degrees in counseling or social work there, but among those folks too, and psychologists, underrepresented representation of Asian Californians. And I think that's a particular concern because we know those are communities in which cultural values and beliefs affect people's willingness to seek help, and where folks really need someone who shares a culture and language to feel confident and seeking out services. I want to turn briefly to the pipeline of trainees in the behavioral health professions, our future workforce. This graph plots numbers of first-year residents in psychiatry in California from 2008 to 2019. And I think the good news here is we had an increase of about 54 first-year residents from 2008 to 2020 in psychiatry. The bad news is this probably isn't nearly enough to meet our need for psychiatrists, which we'll get to a bit later. This graph here plots graduates in clinical or counseling psychology and social work programs. I should say these data and some of the other data are a little outdated, and we're going to be updating that information in the new year for a new project. But here you can see the trends. There was a big uptick from 2009 to 2013 in graduates from master's in clinical counseling psychology programs. That's sort of leveled off since then. Now turning to future supply and demand, and I should say this is future supply and demand pre-COVID, because we did this work in 2017, 2019. And at that time, we projected that California would have insufficient numbers of licensed behavioral health professionals to maintain current levels of utilization in 2028. So that is looking at rates at which people were using behavioral health services in the mid-20 teens, and then pushing those out to 2028, taking into account growth in the population between now and then. And so we projected insufficient numbers. And if you look over on the left side of the graph, those are the number of additional psychiatrists, psychologists, LCSWs, LMFTs, and LPCCs that we project would be needed to maintain current utilization in 2028. We pulled out the psychiatrists separately because they are allowed to prescribe medications. And for some folks with severe mental illness, even moderate mental illness, medication can be an important part of treatment. We did not disaggregate the non-prescribing clinicians because there's so much overlap in their scopes of practice that we didn't really feel very confident that we could disaggregate that well. I want you to move then over to the right side of the graph and notice that the numbers are bigger. These are analyses in which we took into account unmet needs in the pre-COVID era. So there's very robust evidence that there are numbers of people out in California and elsewhere who would benefit from behavioral health services, but do not use them, either because they're not in a place where they're ready to use them, but other times because there are people who would really like to utilize services but have trouble accessing them. And so when you factor those unmet needs pre-COVID, you see big increases. And I don't have a precise estimate, but I think you could say layer on top of that to meet the unmet needs for in the COVID pandemic era. So some really big challenges that we face here in terms of getting a workforce that's large enough and geographically distributed enough and diverse enough to meet needs. So a little bit about policy. I'm going to draw largely on strategies recommended by the California Future Health Workforce Commission. I had the pleasure of serving as a staff consultant to that commission and think that they've made a lot of excellent recommendations for behavioral health workforce as well as other areas. So first, we clearly, I think, need to invest in increasing the number of behavioral health professionals, and we can do this by increasing positions, particularly in psychiatry residency programs and psychiatric nurse practitioners. That's the other group of clinicians that have expertise in behavioral health and also the ability to prescribe. Also want to strengthen training in behavioral health for primary care providers. That given this big shortage of behavioral health professionals, and given that many people present first to their primary care provider when they have behavioral health needs, then how we can enable our primary care clinicians to be more sophisticated at identifying people at risk for having a behavioral health condition and contributing to the treatment, particularly of those with mild or moderate illness. And then want to talk about racial, ethnic diversity, clearly important. And a lot here has to do with the pipeline. You need to expand and scale the pipeline of programs that focus on getting students from underrepresented backgrounds into the behavioral health professions. We also, I think, need to look at funding, scholarship, and loan repayment for behavioral health professionals who practice in underserved areas. Many of our underrepresented young students come from disadvantaged backgrounds, struggle to pay for their education. And in addition, we have areas of the state that are rural, that are underserved, that lack sufficient clinicians, period, and a need to provide incentives for folks to practice in those areas. Well, I'm getting the flashing light, so I am going to stop sharing my screen and turn it back to Professor Rodriguez.
Thanks, Professor Kaufman. Really rich data. Thanks for all of the late-breaking data that you present, really helpful for our discussion. I'd like to turn now to Dr. Marlene Martin, who's an assistant clinical professor at UCSF and leads the addiction team there. She's a physician researcher and hospitalist at Zuckerberg San Francisco General and an expert in addiction medicine. She works to use community-engaged approaches to improve care transitions and outcomes for vulnerable populations, particularly those with substance use disorders. Dr. Martin was born and raised in LA and is a first-generation college graduate. She attended undergraduate and medical school at Stanford University and was an NIH Fogarty Scholar in Peru. Thanks so much, Dr. Martin, for sharing your experiences in the field with us.
I will be talking about expanding California's addiction workforce, a call to further action in response to COVID-19. I am primarily a clinician. I trained in internal medicine, and while caring for multiple patients, Latino patients with complications of alcohol use disorder, that's really what inspired me to pursue addiction medicine board certification and better care for our patients with substance use disorders. So first, I wanted to focus on the national landscape of substance use disorders pre-COVID. We had more than 40 million people with an alcohol, drug, or tobacco use disorder in the United States. According to the National Survey on Drug Use and Health, as you can see in this diagram, about 2/3 of the people with an alcohol or drug use disorder actually had an alcohol use disorder, and the other third had a drug use disorder. What we also know from this survey is that substance use occurs in similar rates across race and ethnicities. However, what we see in practice and in life happen is that the consequences of substance use are very different based on your skin color, and the access that people have to care is also different. When we think about substance use over the last couple of years, we also see that there's been a huge focus on the opioid overdose epidemic. And what you can see in this dark blue line is, in this hockey puck style curve, is that the number of overdoses occurring due to synthetic opioids like fentanyl is rising at these really alarming rates. And it's really concerning. And it's one of the reasons that we've had such a focus on the opioid overdose epidemic over the last couple of years. It means that there's more than 130 people every day in the United States that are dying of an opioid-related overdose. These deaths are preventable. You know, so many people are dying that in some age groups, you actually see life expectancy decreasing. But I also think there's a whole other reason that we've been really focused on the opioid overdose epidemic, and that's because of how this narrative is being framed, right? This narrative has really been framed as an epidemic that has affected white individuals. And some of that has resulted in funding, but that funding is really restricted to opioids. And we have to think about what voices are being excluded from this narrative and who's not getting the care they need. And also, even within opioids, how this narrative might be propagating further inequities. For example, in Philadelphia in 2019, there was a 3% decrease in overdose deaths among white individuals, but they actually saw a 14% increase among Black individuals and 24% increase among Latinx individuals. So really, opioid overdose deaths are the tip of the iceberg in our country for our country's addiction epidemic. And it includes everything from unhealthy substance use up to severe substance use disorders, and lots of other substances that increase the risk of overdose. And the other part of this picture that we have to put together is what is driving substance use, right? And that's really what we're talking about today. So how is isolation and unemployment and mental illness and experiences of homelessness and poverty? These are some of the factors that drive substance use. And as we begin to paint this whole picture and really put it together, then we can begin to think about how to prevent addiction and really start early on, and how to better treat the communities that are suffering most from the consequences of substance use disorders. And as you focus on some of the things that I've highlighted on yellow, the drivers of use, now think about what COVID is doing to this really. And COVID is magnifying the drivers of use. Just, you heard from Dr. Kaufman that anxiety and depression is increasing in the setting of COVID. And I have seen that personally among my patients with substance use disorders. And so people are having more risky use, right? They may have drank alcohol outside of their home. Maybe they're not home and drinking alone. People who had access to syringe access services and now they don't, and perhaps they're reusing needles and they're at increased risk for infectious complications from substance use. And then we've also seen a return to use. So people who were in their recovery and using their support systems, right? Exercise, AA meetings, et cetera. And some of those are not available in person to individuals. And we see this corroborated in the media, and we keep hitting records that I am not proud of. 72,000 deaths in 2019 related to drug overdoses. And we saw in the first couple of months of the COVID-19 pandemic that we've already, we're going to surpass that number, unfortunately, in 2020. In Virginia, in one emergency department, they actually saw a doubling already in the number of overdoses in the first couple of months of the pandemic in 2020 compared to the same time period in 2019. And these overdoses are especially prominent among Black individuals. And it's not just opioids, it's really all substances. And, we've had a 54% increase in alcohol sales in the first couple of months of the pandemic. And we already had an increasing trouble with alcohol use disorder, where we've seen increased morbidity and mortality from alcohol use. And then again, post-pandemic, in the setting of the pandemic, we've seen a more than 40% rise in unhealthy alcohol use among women. And I just want to share a local example from San Francisco General Hospital, where I practice care. So we have the addiction care team there, which is a consultation service that's multidisciplinary and cares for hospitalized and emergency department patients with unhealthy substance use. And pre-pandemic, we had an average number of 60 consults in the hospital, 60 patients who we were asked to see, and after shelter-in-place orders went into effect, that number almost doubled to 93 individuals per month. And thinking back to that iceberg and the drivers of use and the inequities that we've only briefly touched on, our patients, 40% of them have a coexisting mental health diagnosis, 50% are Black and Latinx, 50% are unconnected to care, 60% are experiencing homelessness, and almost every single patient that we see really wants some kind of help. So putting this picture all together, let's think about the addiction physician workforce. And I want to caveat this with, addiction medicine is interprofessional, the behavioral health fields are. And I am speaking as an example here from the physician standpoint, but I heavily rely on a team of expertise from our patient navigators, social workers, nurses. Our team is actually going to hire an addiction psychiatry nurse practitioner to really provide better comprehensive whole person care to our patients with substance use disorders. So addiction medicine, is a relatively new field. The term was sort of first coined in the 1970s. It was really only until 1990 that the American Medical Association included it as a practice specialty. And in 2016 that it became part of the American Board of Medical Specialties. And this is addiction medicine, not addiction psychiatry, which is a similar but slightly different field. So we have 2,600 ABMS certified addiction medicine physicians and 1,200 addiction psychiatrists nationally. When you break this down by state, we have 76 per state, which means about one physician per 126,000 people. And, there's really limited data on what we know about the physician addiction medicine workforce in terms of race and ethnicity, and in terms of where they're located. And this is such important data because as we think about the individuals and our state's population, we really need a diverse workforce that reflects the diversity of our state and the diversity of the the individuals who are being affected with substance use disorders. And just as an example, let's compare this to other specialties where in cardiology, we have 33,000 cardiologists. That's 9 times more cardiologists. We have 8,000 nephrologists for 660,000 people with chronic kidney disease, right? We have, I told you, more than 40 million people with a substance use disorder. 20 million of those have an alcohol or drug use disorder. So we really need to do better to improve the behavioral health for our state. And I want to end with thinking about how we can take action. And I've highlighted the areas in terms of individual, organizational, and policy changes that we can make, what the needs are, and a couple of actions and examples. And I would like to just focus on 2 policy areas: the increased access to treatment. And for me, increased access to treatment really has to include harm reduction, which is clearly evidence-based treatment for people who use substances, and then building our workforce capacity in the areas that are most needed. And thinking about increased access to treatment, just one, we can really learn from some of our neighboring states. Oregon just passed Measure 110, which decriminalizes small amounts of drug possession and increases access to treatment. And perhaps that's something that we can think about enacting in California. During COVID-19, we've had the relaxation of some of the policies around getting methadone and buprenorphine for people with opioid use disorder. And, a lot of these policies are currently being evaluated. And I really think with so much red tape around addiction treatment for my patients, these policies that have made it more accessible to our patients really need to remain. And then, I hope that California can be a leader in implementing and evaluating safer consumption spaces and really learn from other countries that have done this wonderfully as a form of improving care for our patients with substance use disorders. When we think about building workforce capacity, I want to highlight 2 things on here. One is funding and expanding addiction training programs. This is not just addiction medicine fellowships, although we have an HRSA grant that provided funding for 6 fellowship programs in California, including one at UCSF. but also for advanced practice practitioners, nurses, social workers, and pharmacists. And then thinking about funding local pipeline programs to increase the diversity of the workforce and really expose people early on to behavioral health so we can build a pipeline of future workforce. And I'd like to end there. Thank you.
Thank you, Dr. Martin. That was wonderful. You had the bird's eye view and the frontline view. So really took us from big picture to the microsystem. Really appreciate your perspective. Our last speaker is Dr. Elizabeth Saenz. Dr. Saenz is a postdoctoral fellow at the University of California, San Diego Department of Family Medicine and Public Health. She holds a PhD in social welfare from USC School of Social Work and an MSW from Columbia University. Dr. Saenz studies the implementation of interventions that promote self-management among persons with mental illness, including peer mental health providers and integrated behavioral health services. She also teaches courses related to social work research methods, program evaluation, and practice in healthcare settings. Thank you, Dr. Saenz, for sharing your work with us today.
Oh, sure.
Perfect.
So today I'll be talking about practice facilitation to strengthen the behavioral health workforce. So, sorry.
There's a small gray arrow, yeah, on the left corner.
Oh, there it is. So what will we cover in today's talk? We will first define practice facilitation. We will illustrate how practice facilitation can advance system transformations to deliver integrated behavioral health care. And we will describe opportunities for practice facilitation to develop California's COVID-19 era behavioral health workforce. So to begin, what is practice facilitation? It is work done by consultants who support health systems in making changes to improve patient outcomes. These changes can include the adoption of evidence-based practices and guidelines, and these individuals build system capacity by using project management and quality improvement skills. And the practice facilitators that I have worked with in the past have been external to these healthcare systems and are part of just organizations in the private sector and are often behavioral health and medical providers themselves. So while this model originates in the corporate sector, facilitators have been used for a long time in general medical settings. So they were used to assist practices in transitioning to patient-centered medical homes, as I mentioned, adopting evidence-based practice guidelines, and they're increasingly being used to develop the behavioral health workforce. So an illustrative example is from the Behavioral Health Integration and Complex Care Initiative. So like many health systems, the Inland Empire Health Plan, which is a nonprofit Medicaid managed care plan, was struggling to meet the needs of patients with complex behavioral health conditions. So following the Medicaid, or Medi-Cal, if you will, expansion, IEHP was in a position of having too few providers who were disconnected with the behavioral health system. So in response to this issue, they devised the Behavioral Health Integration and Complex Care Initiative, which supported practice transformation in 12 healthcare organizations. And the purpose of this was to engage providers in testing and implementing changes needed to develop integrated complex care management teams in collaboration with local healthcare organizations in the community. And an important component of this work was that they did this with the support of practice facilitators. And so while so this initiative occurred in San Bernardino and Riverside counties in the Inland Empire, as Dr. Kaufman mentioned, there is a severe shortage of behavioral health providers. And while there were an array of goals to this work, the primary one was to improve the physical and behavioral health outcomes for patients with complex chronic conditions. So the participating sites represented behavioral health clinics, federally qualified health centers, and pain management programs that prior to the initiative either provided physical or behavioral health services, but really not both. And so under the initiative, the practices were asked to develop multidisciplinary care teams, which included a care manager who would then connect the patients to a core group of providers, including a primary care physician and nurse and other behavioral health clinicians, as well as a variety of consultants. And so to assist with this transformation process, practice facilitators, they gave individualized hands-on guidance to support successful implementation of integrated care, chronic disease management, and person-centered healthcare. And so they met with healthcare teams in person monthly for about a half day to foster these really collaborative relationships and to provide guidance in key areas of practice transformation. And also to observe the progress of transformation. So we conducted semi-structured interviews with 8 practice coaches and 77 staff members from the 12 participating healthcare organizations. And following the best practices of qualitative thematic analysis, we aim to further understand how these facilitators contributed to system transformation. And we found 3 themes. And the first was that they really developed a very rich coaching model. So under this theme, we learned that the facilitators were highly credentialed in their specific fields of behavioral health or physical health. And then to communicate effectively with providers from medical and behavioral health disciplines, some teams were paired with 2 coaches, as they were termed in the initiative. And usually one had a behavioral health background, who was a PhD or a licensed clinical social worker, and another facilitator with a background as a primary care physician. And so here you can see in this illustrative quote that, as one practice coach indicated, the healthcare system is so full of really entrenched physicians and behavioral health clinicians. So helping them change definitely requires that they interact with people that they respect. And so something a little more provocative that someone said was that, and docs only respect docs. So the second theme pertains to workforce development specifically. And so the coaches developed the workforce by helping clinics find their own answers. And so while coaches saw their role as being a combination of cheerleading and giving feedback, they were clear that they stopped short of doing the job for the participating clinics, though they did help clinics sort of triage and prioritize the things that they needed to work on. And several programs reported that practice coaches were especially supportive in helping teams consider team experience and patient experience in ways that they had not previously. And how facilitators accomplished this was very organic. And tension emerged later in the initiative as the health plan attempted to make this facilitation process more standardized. But here in this quote, you can see that this is a quote from a facilitator, that your job is not to do their job. Your job is to look at what's going on overall in terms of implementing the program. And you want to interface with the teams in a way that they feel encouraged. And so the third theme pertains to how the coaches represented the face of the initiative. And so although facilitators were outside consultants who were part of an organization working in the private sector, they still represented the face of the initiative to the participating programs. And the providers were initially skeptical of having support from a practice coach due to concerns that the facilitators might be overly controlling of their programs. But many providers really appreciated an organizational liaison who could facilitate communication between the program and the health plan. So as one provider here mentioned, a great asset, that the coach was a great asset, where she plugged me into all of the meetings that I needed to go to, all of the information I needed to read up on what BHI CCI is, because this is a very new way of delivering care for the providers that were involved. And many of them, nearly none of them, in fact, had worked across sectors in quite this way before. So in sum, from that research, we learned that practice facilitators developed the behavioral health workforce under the Behavioral Health Integration and Complex Care Initiative by establishing this rich interdisciplinary coaching model where they worked hard to connect with providers of all different backgrounds, by building the skill set of diverse providers to deliver integrated behavioral health care, and also by liaising between the clinics and the health plan in a way that was respectful and accommodating and engaging for everyone. So while there were no peer supporters or peer providers, that is persons living with lived experience, in the BHI CCI kind of at the surface, or that we knew of, I guess I should say, persons with lived experience, of course, are critical to a recovery-oriented behavioral health system. But health systems do struggle to hire and support peer workers. So I'm I'm currently working with a team from a research nonprofit called Live and Learn and some other collaborators on a study that follows the trajectories of persons who have completed the certified peer specialist training, which is a training for persons with lived experience that is recognized in many states and is often required to hold a peer provider position in many places. So we're following the trajectories of persons who have recently completed this certification. And through our qualitative interviews, we have learned about the barriers that peers might encounter in seeking employment. So in addition to the many pandemic-related challenges, including furloughs, of course, peers also mentioned a need to work limited hours to avoid disruption of their social welfare benefits. So as one peer here stated, I have to fight with them being my employer, about how many hours they wanted me to work because I have the state's Medicaid. So you have to be poor, but I was just a temporary worker because that was the nature of the position. And so to keep my benefits, I couldn't work. And so another application of practice facilitation could be to develop the peer support workforce. And this is not only my own suspicion, but this is in fact in the words of one of our study participants who actually has an interest in this work that she shared with us during the interview. According to this study participant, what if there was an official implementation team or a capacity building team where when an organization decides to take on CPSs, the team comes in to facilitate that process so that you don't have a CPS, which stands for Certified Peer Supporter, either sitting around doing nothing or overloaded with work that is not part of their job description or above their pay grade. So in conclusion, facilitation is a promising practice for the development of the behavioral health workforce. Facilitators can liaise between health systems and providers to deliver integrated care. They can support health systems in creating space for peer supporters and understanding what the challenges are that peers might have in finding work, and might help health systems also create these positions with their specific expertise in mind. And it can clearly develop system capacity while increasing provider skills. So some thoughts on how practice facilitation might look in a COVID-19 health system. I think this is a really critical moment for something like practice facilitation in supporting clinics and adapting services given rapidly evolving public health guidelines. And there are a lot of changes that need to be made with respect to how services are delivered, whether it's integrated behavioral health or services that are delivered by peer supporters. And some of them might relate to scaling up telehealth, and others might relate to how to reach those people that do not have that technology at their disposal and still might require home visiting, residential treatment, et cetera. And then also importantly, in a COVID-19 health system, since we are all apart when we're used to being together and at least touching base, healthcare teams used to touching base weekly or ideally more, it can really, practice facilitators can really help buffer against misunderstandings between people who are not seeing each other, and where we know that there's so much misunderstanding can really happen when we're not able to be together. And in terms of scaling up this model, I think that the first step is really formally establishing the evidence base. I think that the coaching model is not quite standardized, and it's one of those things which is very difficult to do because health systems have their own needs, and it's sort of this personalized approach to doing care. But one thing that could be standardized would be like the education and training that is required of practice facilitators, because in the literature that is not consistent. And I have more thoughts on how to scale up on a policy sense, which I can wait until the discussion. So with that, I will share my references with you, and I look forward to talking more in the discussion.
Great, Dr. Saenz, thanks so much for this incredible information and late-breaking work on peer support specialists. So thanks for sharing those late-breaking findings.
I'm glad to. Some of them I spoke with just a day or two ago. So
awesome! It's really hot off the press. So I have the pleasure of introducing our final panelist and moderator of the discussion in the Q&A, Stephanie Welch. Stephanie Welch is Deputy Secretary of Behavioral Health of the California Health and Human Services Agency. Stephanie previously served as Executive Officer for the Council on Criminal Justice and Behavioral Health, was a Senior Program Manager for the California Mental Health Services Authority, an Associate Policy Director of the County Behavioral Health Directors Association, and Associate Director of Public Policy at the Council of Community Behavioral Health Agencies. She comes with a wealth of professional experiences in the field in this area, and we're happy to have her lead our Q&A. Thanks, Stephanie.
Thank you, and thank you so much for having me here to talk about one of my favorite subjects. You know, I think I always like to share, especially if there are students out there watching. I came into this field as someone who was a peer. I had been in the mental health system, and I was really highly motivated to figure out how to work in the policy field to improve the system. And one of the first things I learned was the value of peer support and the value of people with lived experience working in behavioral health. And I think what has become even more evident, something that was always there, but is more evident and raw because of COVID and because of the racial injustice reckoning that we're having in our country right now, is these incredible disparities that we have and the lack of an appropriate workforce, people who look like the people that they serve, and also really importantly, bringing those life experiences. I most recently worked very closely with folks who are working in correctional settings and working in probation and things of that nature. And the additional lived experience of having been involved in the justice system was a tremendous asset for effective delivery of support services for folks who are in our substance use and mental health treatment programs post-incarceration. So this is a wonderful opportunity to explore how to really scale up our ability to employ people who have lived experience, and also to think about the pipeline, the workforce pipeline. We've had such a broad discussion here today, everything from a lack of psychiatrists to wanting to make sure that peer support specialists are appropriately trained and supported, and quite frankly, given the kind of living wage that they need so that they can move on and have a full, fulfilling life and career. So with that being said, what I'm going to try to do in our very limited time is make sure that I have a poignant question for each of our panelists. And then hopefully if there's time, I have one question that's really probably selfish because it's focused on what the administration that I work for should be doing to support these efforts. And hopefully we can get to all of those. So I'm going to go ahead and work my way from our most recent speaker, Dr. Science. So what policies do you think and or state agency action we should take in order to better support facilitation or practice facilitation being employed to improve services?
So I think that's a really great question. And as I mentioned in my presentation, I think that the first step in that is really establishing the evidence base and prior to a large scale rollout of such an approach. And one way of doing that would be maybe perhaps starting at the county level. So here in Los Angeles, we, my group at UCSD, we've been project evaluators for a number of Mental Health Services Act funded initiatives where we have been the contracted project evaluators. And so trying this out at the county level while you're doing, implementing some kind of new service, there could be a range of things that the practice facilitators could be helpful with. And then you could start establishing that robust evidence base that you need to kind of scale it up in a way that it's meaningful and effective. And like I said, I know that the Mental Health Services Act has funded a lot of the programs that we have been part of. So that might be one sort of avenue to take.
Great. Thank you very much for that suggestion. And Dr. Martin, you know, I really appreciated your focus on, or your bringing to our attention that there is this kind of focus on the opioid epidemic, yet people are suffering from very different substance use disorders, and we have some limited funding. It's a lot of the federal relief, while we desperately need it because overdoses are a real issue, especially with the justice-involved population. We have a significant number of people who are experiencing other substance use disorders and, quite frankly, polysubstance use. And so could you talk a little bit about how that narrative and that focus on opioid addiction has increased inequities? You did a little bit in your presentation, but do you have any suggestions on what kinds of messaging or policy changes or other behavioral health transformation, behavioral health care delivery transformation we should focus on in order to reduce disparities?
Thank you for that question. You know, the reality is that most of the people that I see in the hospital often use more than one substance. That increases like the risk of overdose. Many of the drivers of substance use are also very similar across the individuals we're seeing affected by unhealthy substance use. And then, you know, you also see, you know, one program that we have in my hospital, it's a SAMHSA funded program that provides intense case navigation for patients with opioid use disorder who are new medication starts. So they are newly started on methadone or buprenorphine, for example, and they hadn't been on it in the last 2 weeks prior to their emergency department visit or hospitalization. And so this is wonderful, right? Because this program assigns a case manager who meets you in the hospital and cares for you, or in the emergency room, sees you for your visits for 6 months. But if you have stimulant use disorder and you don't have an opioid use disorder, you're out of luck. If you have alcohol use disorder and you don't have an opioid use disorder, again, you can't participate in this program. And so then thinking about, you know, my patients with alcohol use disorder, many of them happen to be Latinx. And then, you know, they don't have access to this, and they also may have limited English proficiency. They may want to go to residential treatment programs, but many of the residential treatment programs in San Francisco, for example, don't have the language capabilities to be able to provide the services that they need. So I think as we really think about providing better addiction treatment across our state, we need to expand funding beyond opioids, and to really meet people where they are, which is like one of the main tenets of addiction treatment. And then the other part of this is treatment means different things to different people. And for my patients, treatment means making today and tomorrow better than yesterday based on their goals. And so that means that treatment is harm reduction. We have so much evidence based that harm reduction works. It decreases hospitalizations, acute care visits, emergency service use, deaths, infections, etc. And so we really have to be able to find ways to fund some treatments for people, especially stimulant use disorders, where really the most effective treatment is behavioral interventions like contingency management. And I think that's where we have to move forward with our escalating addiction epidemic.
Thank you. Excellent comments. Thank you very much. And Dr. Kaufman, you provided some slides and shared some data about the significant lack of psychiatrists that we have. And psychiatrists play an important role for people with serious mental illness who needed an appropriate diagnosis. Can you tell us a little bit more about how you think we can overcome the challenge of oftentimes psychiatrists not accepting insurance, even though we've had these great strides made with getting more people insured? We still do have that lack of psychiatrists. And if you have any suggested policy changes that we could pursue in California in order to increase those numbers.
Excellent question, and I would note in the work that we've done in the past, psychiatrists were the specialty among physicians least likely to accept insurance. So this is a big deal. I think part of this is over the long run, who we train as psychiatrists, and being more proactive at the medical school and residency level at admitting people who have a passion for caring for the underserved, people from diverse racial, ethnic backgrounds. We might, I think, for psychiatry residency funding, do something like the Song Brown program and the Cal MedForce programs that we have in primary care, where priority is given to funding residency programs that have a track record of training clinicians, training physicians to practice in underserved areas. I think we also need to sort of maximally leverage telehealth so that we can maximally utilize psychiatrists across the strait. I think we also want to invest in training psychiatric mental health nurse practitioners. Now, their training is not the same as psychiatrists, but they can prescribe, and they have a high degree of specialized training in behavioral health. And certainly there are ways that they can partner with psychiatrists, partner with primary care physicians to be part of the solution. I should say primary care clinicians of all stripes. And lastly, to leverage our primary care clinicians to provide more behavioral health training for them. And we have a great model for that in the UC Davis, UCI primary care psychiatry fellowship that could be taken to scale.
Great. Wonderful and very specific examples. Thank you. You know, I think we have a little bit of, I know we're over, but we're going to go ahead and move forward with just one last question, because I also want to make sure that we have the opportunity to have Senator Bell answer this question. Because of the legacy that you leave, we were talking about it earlier. I've had the pleasure of trying to persuade you and lobby you for many, many years now. And you have just been able to make a lot of accomplishments that have been really critical to the evolution and progression, frankly, of the mental health delivery system here in California. So with that being said, I want an opportunity for each of the four of you to answer this question that would be, I know, very helpful to me in my role in trying to advise the Secretary and the administration on how to move the ball forward when it comes to progressive behavioral health policy. So what would you suggest, or what bold change would you suggest the Newsom administration take in order to meaningfully move the needle forward when it comes to behavioral health care, workforce diversity, and equity? And Senator Bell, if you don't mind, do you mind if we go first with you? I think we're going to unmuting you.
There you go. Can you hear me?
Yes.
Okay, I think when you look at the politics of this, let's look at what happened in November. I mean, Proposition 20 was the one that rolled back the criminal justice reforms that Governor Brown and the legislature instituted over the last 10 years. And that failed, with 62% of the people in California voting no on Proposition 20. And that was supported by law enforcement. They said it was going to be more crime and we should roll back all those reforms. Well, we defeated that proposition. So what I think the governor and the legislature need to do is do a comprehensive set of bills on mental health and housing for people, so that we can have a continuum of care in mental health, and focus on, of course, prevention and, of course, treatment, and then designed to reduce the acuity of people. I mean, we're facing budget problems, so we have cost drivers, and the cost drivers are the criminal justice system, the emergency room, high acuity healthcare. So how do you reduce all those areas? And I think the legislature can devise a package of bills that accomplishes that with your help. And part of it is to increase the workforce. And schools should be free. I think we should have free addiction treatment for everyone. The insurance companies should be required to not put barriers up for addiction treatment and mental health care like they have been. I've, of course, fought them tooth and nail. And I think when you look at this from a budget standpoint, I think the Department of Finance has to come up with a different vision than they have now, because they basically oppose all the mental health bills that I've ever done because they don't view any cost savings. I think they have to look at it on a more dynamic standpoint like Congress does. I think what we're going to see is some bills next year that deal with a more comprehensive vision of mental health. It would be a package of bills. It won't be like one bill for everything. It'll be a package of bills. And I think the most important thing that we need right now is we need leadership, and Governor Newsom himself is the one that has to provide that. Governor Newsom has to have somebody advising him on mental health, and he needs to do what he said he was going to do. He's going to have a drug czar, a mental health czar. He hasn't appointed anybody. We had Dr. Insel there for a while, but he left, and we need to have somebody advising the governor on these issues. Maybe he ought to promote you, Stephanie. But somebody's got to tell him, here's the comprehensive vision. and he needs to pull it together. And he's wasting time. People are getting ill. There's people dying. The overdoses are getting bigger. The mental health treatment system's becoming overwhelmed. We have to treat this with some sense of urgency. So I think the legislature needs to look at it as attack the cost drivers, because it's a budget problem. We have budget problems. The legislative analyst report that just came out a couple of days ago said we have a little surplus now, but in the next few years there's going to be deficits.
Right.
So I think that's attacking the cost drivers. Cost drivers essentially are untreated people. If you look at it that way, untreated people cost more than actually doing the treatment in a medically necessary way. So attack that. I think that's the solution.
Great. I really appreciate your insight, and I think speaks so much to the need to have a diverse workforce, right? Everything from peer providers to people who can prescribe, and all of that in the name of keeping people in the lowest level but most appropriate care. So thank you very much. Let's move to, I'm just looking at my screen, and Dr. Kaufman, I have you next. What would be a bold recommendation that you would make to the administration to improve the behavioral health workforce and its diversity?
Well, so I think everything that Senator Beal has said, some specifics would be really investment in career laddering. So for those folks who enter the behavioral health workforce at a position that, say, doesn't require a college degree or only requires a bachelor's degree, to really make it more seamless transition for folks to get the education they need to practice at a higher level. I think on the psychiatry front, we really need to start seeing psychiatry in some ways as part of primary care. We have, as a state, invested a lot of money of late into training primary care physicians, primary care residency programs. That's extremely important. But we also, I think, need to make similar investments in psychiatry, our budget issues notwithstanding. And then something that goes beyond what I talked about, but I feel is extremely important, is improving first response to people who are having a substance use or a mental health crisis. We lose way too many people because folks in crisis interact with law enforcement officers who aren't able to de-escalate the situation. And we have some models across the state through our community paramedicine pilot projects, and the legislation authorizing community paramedicine statewide was signed into law this year. So really looking at those models where paramedics are partnering with law enforcement to de-escalate and divert people in crisis to either sobering centers or mental health crisis centers, and seeing if we can take that to scale to help some of these folks who are the most vulnerable among us.
Yeah. Really appreciate you bringing up that important point about engagement. If you don't have a good experience the first time you're interacting with the behavioral health system, why would you go back? So really, that's such an important point, and our workforce and who those people are to meet you in that first engagement is really, really critical. So thank you for mentioning that. Dr. Steins, do you have a thought on what would be a big, bold step that the administration could take to improve workforce diversity?
I do, and this is especially with the given the recent passing of SB 803, if there's about to be an increase in the number of certified peer specialists in the California's behavioral health workforce, and I think that actually goes really that my presentation today on practice facilitation could be something that can support health systems in creating positions for these new peer specialists, newly certified peer specialists, and working at the interface between health systems and the frontline organizations that are going to be delivering care. So just to make sure that peer providers are being given reasonable amounts of work, and so that the health system can understand the challenges they might experience in participating in those roles. Thank
you very much. And what a legacy to have, Senator Bell, that 5 5 years from now, someone's going to be able to walk into Kaiser, right? It provides a great majority of services here in California, and someone might be able to be assigned a peer provider. How amazing would that be? Awesome. So, last but not least, Dr. Martin, what would be some of your ideas for a big, bold action that the administration could take to address workforce diversity?
I think about this a lot as a Latina woman who is the daughter of immigrants who works in the safety net system really because of my background. And I happened to fall into the area of addiction medicine because I saw this unmet need for my patients and many patients affected by alcohol use disorder. And, you know, now I care for lots of patients affected by the opioid epidemic, right? And stimulant use disorders and people experiencing homelessness and all of these things. And I think about just such our need to really invest in equitable education. And right now, thinking of like schools all being lots of schools being closed, especially public schools, where many, you know, communities of color rely on for education and further inequities that are being created. And I was just so sad to see that affirmative action did not pass in California, because those are the things that we need really if we want to invest in communities and we want to lift people up and we want to create more diverse workforce, not just in healthcare, but across, and give people really equitable opportunities. That's what we need. We need people to be able to, you know, give up some of their power to be able to lift others up. And so I would like us to think about how we can provide more equitable education and diversify not just healthcare, but many other fields.
Well said. Well said. I guess I want to kind of put it back to Hector. Is there time for any of the panelists to share some final thoughts, or do we have any questions from the audience that we should be fielding?
I think we're probably going over time now and losing folks, so we probably should wrap it up. But Stephanie, thanks so much for your excellent moderation of this panel, and let's give all the panelists a round of applause here. Thank you so much. Kalahia will be emailing all the registrants with information about this panel, including a summary and also some of the PowerPoint slides that were presented that aren't that have been published already and out there in the field. So thanks so much again, and let's continue the conversation. We have a lot of work to do moving forward, but there's a lot of opportunity. Thanks so much, everyone.